Introduce the first speaker, who turns out to be a longtime friend and colleague during the days that we were both in Boston, Mira Irons. Mira is the chief of the Genetics and Metabolism Program at Children's Hospital in Boston, the associate chief of the Division of Genetics, associate professor at Harvard Medical School, and holds the Park Gerald Chair. Some of you may remember Park Gerald. Mira will speak this morning on the subject of the genetic evaluation of short stature.
Good morning. I'd like to thank the organizers for the invitation. And I am Mira Irons. Just to tell you a little about how I got involved in the genetic evaluation of short stature. The reason this came up is I was asked to co-author the guideline for the evaluation of short stature by the PP&G committee of the college. And before I do anything else, I really have to give credit to Lori Seaver, who was my co-author in this and was actually the first author of the guideline, I didn't turn this on. Great. Who really did all the heavy lifting on this guideline. And then it really is a collaborative experience after that. The way the college PP&G committee works is that two or three people actually initiate the guideline, and then there is a lot of committee involvement, both from the PP&G side, the college board of directors, and also the membership of the college. So this guideline was really not just written by the two of us, but a lot of people. The other thing I wanted to tell you is that this actually looks very busy, and I will, this thing isn't working. Here it is. I will continue to come back to this to try to make some sense out of this. A very interesting thing was just before I left, one of my junior faculty who didn't know that I was coming to give this talk he turned to me and he said, "You know, Mira, I really like that algorithm, and I use it a lot, so hopefully it will make some sense today." So the important things to know before we go any further is, what is the definition of short stature? It's an easy definition. It's height for age less than 2 standard deviations below average for gender, or basically length or height that are less than the 3rd percentile on the growth curves. That's the first problem. The growth curves are actually based on the North American population, and the patient that you're seeing may not fit into what we used to call the typical North American population. The other issue is that there is currently no evidence-based literature to support the diagnostic evaluation of short stature by the medical geneticist. There are 1 or 2 papers in the literature. Most of the papers are actually in the endocrine literature or the general pediatric literature, so that there was really not much to go on in putting this together. The other issue is that the role of the geneticist may actually vary based on location and practice setting. Where you practice and the type of practice that you're in may make your role different. So the geneticist may actually be the first or only person to evaluate the child with short stature, so that we have to not only evaluate kids for the things we're comfortable with, syndromes, skeletal dysplasias, chromosome abnormalities, but all those kind of general pediatric and endocrine things that you have to keep reminding yourself about. Or geneticists may actually be the second line of defense. You know, all of the non-genetic things may have already been ruled out, and we can actually practice on the right side of that algorithm that we're more comfortable with. Or we may actually be just asked to be involved in the genetic testing. Someone may have said, "I think this child has this. I'd like to send this genetic test, and how do I send a genetic test?" And then your role may be easy or difficult depending on whether or not you agree with that diagnosis, and whether or not the test has to be sent. So what's the differential? It's pretty broad. Occult systemic disease, constitutional delay, familial short stature, both pathologic and non-pathologic. I like to say that just because you look like your parent doesn't mean you're normal. Endocrinopathies, genetic disorders, chromosomal recognizable syndromes, and I separate out the skeletal dysplasias, although understand that they are recognizable syndromes. So what's the end result? I think it's good to kind of start there before you actually go into the process, because you have to know what the playing field looks like. And what it looks like is that there's one paper actually in 2002 from China that looked at 353 patients with short stature, and half of them had constitutional delay or familial short stature. And this is familial non-pathologic short stature. So right off the bat, half of them are really nothing that anyone really has to worry about. If you take the rest of that, 19% are chromosomal, and most of those are Turner syndrome and variants. Only 3% are multiple malformation syndromes, and 2% are previously unrecognized endocrine disorders. So that's as good as it's going to get. So once your chromosomes have been sent, you have about a 5% chance of either diagnosing a recognizable genetic syndrome or an endocrine condition that maybe the endocrinologist didn't see. So back to the guideline, and we're actually going to start with this side of the algorithm first, because this is the part that at least I was much less comfortable with than this side. So when we went, just to start, we sort of divided this up into isolated short stature or short stature with other things. So to start with isolated short stature, the differential diagnosis is non-pathologic and pathologic familial short stature, constitutional delay, primary endocrinopathies, girls with X chromosome abnormalities. Now, some people may argue that this is not isolated, that a girl with Turner syndrome really has dysmorphic facial features, but I think we also have to recognize that there's a lot of girls out there who look perfectly fine to their pediatricians and are not really dysmorphic. Those of us in this room may say that child looks like she has Turner syndrome, but the pediatrician may not. And then this was actually the big new information to me, is that how frequent Shox mutations were in this group of patients. So what do you need to know ahead of time? Height velocity is very important. It's the single most useful indicator in addition to absolute height, and you have to determine it over at least 3 to 6 months. Hospitals with electronic medical systems have actually made it really easy. If you have growth charts in your hospital system, you can actually click on the 2 growth parameters and it'll calculate the growth velocity for you. The genetic potential or target height is important. It's actually worth sitting down and figuring this out. Endocrinologists do this at the drop of a hat. But if you're faced with a child with short stature, you have to, we ask family histories a lot. They're really important for us. Asking the parents what their height is really important. And if you add the father's height and the mother's height, for boys, take that sum, add 13 and divide by 2. For girls, you take the sum, subtract 13 and divide by 2. And that's actually going to give you your target height. If you look at the growth percentile that your patient is on, follow it out to age 18. If that target height actually ends up in the right place and the growth velocity is normal, then the child's growing fine. Time of onset is important, pre versus postnatal. The bone age may be helpful. Delayed bone age is nonspecific. A normal bone age actually is more problematic in that there's less growth time available. Weight is actually very important, and it's the way the endocrinologists and the non-geneticists kind of distinguish genetic versus non-genetic causes of short stature. Low weight for height is more likely due to systemic illness or nutritional etiology. And absolute or relative nutritional deficiency usually has weight loss or decreased weight that starts before your height drops off. So if you have a child, if you look at a growth curve and the weight is actually lower than the height, or you saw that weight drop off first, then you're really looking more at systemic disease or nutritional problems. Growth hormone disorders are different. These kids are actually kind of chubby. Their weight is actually above their height or on the normal growth curves. And then look at body proportions. So systemic disease, I'm going to go through these quickly because they're really not what we do, but my endocrinologist friend divides this into hypocaloric and metabolic. Think malnutrition, GI. GI disease may be asymptomatic. So IBD and celiac disease may be asymptomatic. poorly controlled diabetes, worry about the renal, the RTA stuff. Endocrine disorders, as I said, you see preserved weight gain or frank obesity. Thyroid is a big one. I actually just took my MOC exam for general peds. I did it willingly, not that I had to, but this gets, in the review articles, this actually gets stressed a lot. I think it's something that we don't see. You see a short child send thyroids. It's probably one of your biggest problems. Growth hormone and corticosteroid excess. So here are some growth curves. These were taken from a wonderful review, Pediatrics in Review. If you want to read one thing on the evaluation of a child with short stature, this is it. But if you look at primary nutritional deficiency, what you see is the weight actually drops off before the height drops off. And the one place I see this most frequently, because I see a lot of the NF kids at Children's, is kids with NF tend to be short anyway, but then what happens is the ones that are on stimulants end up dropping off. And the growth curves are amazing. The weight drops off, and then within 6 to 12 months, you see the height drop off. And then in congenital growth hormone deficiency, you actually see that the weight is preserved and the height drops off. So screening tests, CBC, SERGG, celiac testing, electrolytes, thyroids, and then if you're really worried about growth hormone deficiency, send an IGF-1 and an IGF-BP3. Don't send a random growth hormone level. It's totally meaningless. And then you'll just have to listen to the endocrinologist yell at you about how absurd that was, and you should have known that. So just to get the big one out of the way, since 50% of these kids have constitutional delay, we ask all those questions that I think maybe other specialists don't. You ask the parents how tall they are. You ask the father and the mother when they went through puberty. But what you see in constitutional delay is you see a deceleration of height in the first 3 years, a normal or near normal growth velocity. It's about 4 to 7 centimeters per year, a delayed bone age and pubertal development, and the final height is actually in the target range. How is that different than familial short stature? Everything's the same except that the bone age is normal, and the height as an adult ends up being short, but appropriate for target height. You know, if your father's 5'7" and your mother's 5 feet tall, you're not going to be 6 feet tall. It's amazing how some people have to be told that. Not just the kids, but the parents. You know, and what you'll hear is, yeah, but my brother is like 6'10", you know. Okay. So just to get IUGR out of the way, because I think this tends to come up a lot. There are 2 definitions to IUGR and SGA. The one I like is 2 standard deviations below the average for gestational age and sex. Some actually use less than 10%. But you know, less than 10% then means you're evaluating 10% of the kids that are out there. One of the endocrine reviews that I looked at recently said that 90% demonstrate catch-up growth by 2 years. The 10% that do not, the endocrinologist will say, are usually dysmorphic or syndromic. I don't know that that's true, but what I do know is that if they don't demonstrate catch-up growth by 2 years, they're not going to. So this is kind of the standard evaluation. I didn't reference this, but this table 6 is actually from the practice guideline. And it's all of the things you would imagine. Take a good history, teratogens, pregnancy, ask about the placenta. It actually pays off a lot. And sometimes you're lucky in that if you do a consult in the NICU, you still have a chance of getting at that placenta. Worry about torch, have an eye exam, hearing screen, torch testing, bone dysplasia survey, if the child looks disproportionate, and then if there's persistent hypoglycemia, worry about endocrine things. So here's the data on the SHOX mutation, and I don't know how helpful this data is because it's all over the place. But if you look at this paper from Clinical Endocrinology just a few years ago, they looked at several studies where they did SHOX mutations in children with idiopathic short stature or isolated short stature. And the frequency is anywhere from 1.1 to 14%. I'm not sure how physical exam will help if it's negative. I mean, obviously, if a child has a Madelung deformity or if there's an abnormal X-ray, you might think SHOX. But the skeletal changes may not be apparent until late childhood or puberty, and they're less common in males. Sort of the story of our life. But here's a pedigree from that study where you actually looked at the colored boxes, circles and squares, are patients in this large family with SHOX mutations. The non-colored are negative. And you kind of get the feeling that the people with SHOX mutations may be a little shorter, but not all the short people have the SHOX mutation, and not all the people with SHOX mutation have the Madelung deformity. I think the only take-home message from this is, if you really don't know what the child has, you might want to think about this, because it may give you an answer, but it's not especially a higher yield. So now moving to that other end of the curve, the other end of the algorithm, the children with short stature and other physical or developmental defects, we divided these up into proportionate and disproportionate. The proportionate include recognizable syndromes, and the unrecognized, the committee decided that array CGH is a reasonable test to do in these patients. We got one response after this guideline was actually published in Genetics and Medicine last June, and that was because we didn't say chromosomes here before we said array CGH. And it was actually someone that said, well, what if the child has Turner syndrome? And we actually thought that that would fall into this category. We put the girls with Turner syndrome into the recognized syndrome specific testing that's available. So if you're wondering where karyotype is in this, it actually kind of falls into that category. And then the disproportionate are the skeletal dysplasias. So this is just sort of my approach to this. In general, a syndrome or chromosome abnormality is more likely if there are other features. That's not news to anybody in this room. If no recognized syndrome is, if you can't think of a recognized syndrome, I think chromosome testing is indicated. When you look at that data from that one study, 19% of these patients had chromosome abnormalities. It's our only high yield test. Most of these conditions are diagnosed clinically with no confirmatory testing available in many cases, and some are familial and others are sporadic. Because I can never do it, geneticists can never do one of these talks without showing pictures. I will go through the common sort of short stature syndromes that we see in the clinic. DeLange syndrome is well known to everybody in this room. I think the classic DeLange nobody here would miss. It's the kids with kind of the mild DeLange syndrome who maybe are kind of at the 5th percentile in height, and they have a little bit of the arched eyebrows and the long eyelashes and a little bit of the upturned nose. Those are the ones that may be a little more difficult to miss, especially those with a normal IQ. Now, as you know, there is testing for DeLange. About half of them have mutations of the NIPBL gene. There are also rare mutations of SMC1L1 and SMC3. I don't think that there is testing for SMC3 available clinically yet, but I may be wrong. Russell Silver is the category that I personally have the hardest time with, because my feeling is that Russell Silver is probably a whole bunch of a lot of things. I mean, think about it. There are very few, if any, diagnostic criteria. There's prenatal growth retardation, there's relative macrocephaly, and there's asymmetry in half of the patients, and clinodactyly of the 5th digit. I always feel better making the diagnosis of Russell Silver if I see asymmetry, and if there's at least 1 or 2 low glucoses in the newborn period that I can hang my hat on. Now things have gotten a little easier. We don't just have UPD testing of 7 for the 10%, but about 35% of these kids do have abnormal H19 methylation. I can tell you that the one child that genetics is all anecdotal, unfortunately, but the one child that I had who did have abnormal H19 methylation is someone that got sent to me as rule out Russell Silver, and I said, I really don't think I don't think he has Russell Silver, but he is asymmetric and he was small So, let's send the testing, and it was abnormal. I just heard about a patient last week who both I and a genetic endocrinologist 7 years ago thought might have Russell-Silver syndrome, who turns out to have a deletion of chromosome 17, a 3.5 megabase deletion on chromosome 17 on a microarray. In the intervening 7 years, that child started to act not like Russell-Silver syndrome. He became more dysmorphic. He had intellectual disability and language abnormalities. And so, not jumping to a diagnosis in the newborn period really is helpful in some of these patients, because it turns out they may have something else. But this does exist, and at least now there is testing for it. Rubenstein-Tabby, I think nobody in this room would miss. I have been told that not all fish is the same, and that some labs will have an appropriate fish test that will identify the deletion in about less than 10%, and others don't. There is testing of the CREB-P gene that will identify about 50 to 70% of these kids, and then 5% have mutations of EP300. Of course, as is the case in most of our lives, these two genes, CREB-P and EP300, are done at two completely different labs. Try explaining that to your send-out lab. Everybody has their favorite syndrome. This is mine. I have to throw that out there, but SLO does present with both pre- and postnatal growth retardation. This is very easy to miss in the newborn period. I see a little SLO in everybody, and I've actually missed 3 newborns. Babies with SLO don't look like they have SLO. The face is not there. They have a very round face. Their eyes are closed in the NICU, so you don't see the ptosis. They may have the upturned nares. They may have submucous clefts, and they may have they obviously have the tooth syndactyly. But at a month of age, they look like they have SLO. So seeing these kids back is important. The diagnostic test is not a total cholesterol. It is elevation of 7-dehydrocholesterol because these kids have a biochemical abnormality. They can't convert 7-dehydrocholesterol to cholesterol. And so the total cholesterol that your laboratories all measure actually measures both cholesterol plus 7 and 8-dehydrocholesterol. So you can end up with a normal cholesterol in some of these kids. It's often in the newborn period the other findings that make you think of SLO, postaxial polydactyly, failure of masculinization in a male fetus. So if you see ambiguous genitalia and you have a Y chromosome, think about SLO. It's the opposite of congenital adrenal hyperplasia. John Opitz really gets excited about their thumbs. I'm not sure it's anything anybody would pick up, but they have this swan's neck deformity of their thumbs. And this is kind of the classic face. I don't think anybody in this room would miss this, but this is the kid that really always worries me. Because this is a boy with SLO, and I can see it right around here. If you look kind of at the eyes and the nose, that child looks like they have SLO. But this is the kid that never gets to a geneticist because no one thinks he's dysmorphic. This is the child that's being followed in neurology clinics with hypotonia and a little developmental delay and maybe some tooth syndactyly. So I think if we're missing any kids with SLO out there who are small, it's the mild ones that we're missing. I always put kabuki in here because I'm absolutely convinced that unless you've seen one, you don't think about it. And once you see a child with kabuki syndrome, you start to think about it. So these kids are small. They have postnatal growth deficiency, and this is one of those cases where they actually develop obesity over time. They do have these characteristic faces, and I think measuring palpebral fissures is really, it's like the big money in this syndrome. You measure their palpebral fissures, and they're like 3.5 to 4 centimeters. It's beautiful big eyes, long eyelashes, and they really do have these finger and toe pads. It's not the only syndrome that has prominent finger and toe pads. but it is one of them. I had a line here that I took out yesterday of unknown etiology. I hear there's a rumor out there that the gene may have been identified. That kind of came up at the college meetings in the hall, but I haven't seen anything, and maybe I just missed it. So there may be a confirmatory test at some point. Williams is sort of your classic example of pre- and postnatal growth deficiency, and either FISH or MLPA testing, depending on what your lab does, for the Williams syndrome deletion is your test of choice. Noonan syndrome is interesting. I did this survey of all the geneticists in my group before I came here, saying, you know, what do you think of when you look at a short child? And one of the most senior geneticists that works with me, who I think is the best dysmorphologist that I've met, said, I always do Noonan testing now. If I don't know what they have, and they're short, and their chest is a little broad, and their ear is a little off. She personally has had a big payoff with Noonan syndrome, and not all of the kids now that have mutations of the 4 genes associated with Noonan syndrome classically look like Noonan syndrome. So in terms of what do you look for, you may have to look for that kind of subtle or mild end of the spectrum. SERGG is my last picture here. These are the kids that I personally have the most trouble with, because I keep thinking of SERGG in a lot of kids and sending FGD1 testing, and it's always negative. You know, if someone would tell me what a Schall scrotum really looks like, maybe it would help. But I think the tip-off in a lot of these kids is many of them really have feeding problems and failure to thrive. The last child that I was absolutely convinced had SERGG testing turns out to have Briggs or Winter syndrome, which became clear as he got older. So it just is another example of how things aren't very easy. So turning now very quickly to disproportionate or extreme short stature. And I'll tell you in a minute why I added extreme isolated short stature to this, because it was really the only argument that we got in putting this algorithm together at the committee level. You know, everyone agreed that you do skeletal surveys in children with disproportionate short stature. I mean, that's kind of, you know, if you do an arm span to height ratio, or if you do an upper to lower segment ratio and it's abnormal, then you can say, I can do the skeletal survey and maybe that'll give me the answer. We did have more than one maybe committee members who actually said that we should do skeletal surveys also in people with a proportionate extreme short stature. So that if you have a child that's less than 3 standard deviations below the mean for height, you might want to consider doing a skeletal survey because it may give you the answer. So this is kind of the skeletal survey that everybody agreed on. If you really look at this, it's like everything. You know, there's nothing sort of special here, but you need skull, you need spine, you need chest and ribs, pelvis, long bones, hands and feet. The lateral ankle and knee, I think, are here for the babies that you think might have chondrodysplasia punctata. As you all know, skeletal dysplasias are classified by skeletal changes. And then, you know, your best friend is a radiologist who actually wants to sit down with you and go through all those real subtle things. You may need to repeat if it's mild or subtle or if it's done too early. And I think there are no guidelines out there as to how often you repeat it. You know, if you see a 2 or 3-year-old and you do a skeletal survey and you get this reading back that says non-specific bony changes, or maybe just a few subtle things, you know, bring them back in 2 or 3 years. Look at the growth and potentially you may need to repeat the skeletal survey. Look at the parent. You may actually get a better pickup by doing a skeletal survey at that point on a parent if the parent is short also. So you may have to repeat it if it's subtle or done too early. You may be too late. The findings of chondrodysplasia punctata sort of go away as that bone calcifies. So, you know, you may have missed the chondrodysplasia punctata in the spine or the knee if you have a child that's 2 years of age. And once again, consider it an extreme proportionate short stature. Just to give you a few pictures from a phenomenal paper that came out this month's Genetics and Medicine that arrived on my desk literally as I was leaving to go to the airport, has a beautiful review by Deborah Krakow and Dave Moyne on evaluation of skeletal dysplasias. If there's one thing out there that you want to read on this, I think it's this paper. And the next 3 slides will actually come from that, which is the beauty of PowerPoint. 25 years ago we couldn't do this, but now we can, where they actually make the point that skeletal dysplasias are defined by the bony abnormality. And so if you can identify an epiphyseal abnormality, a metaphyseal abnormality, a diaphyseal abnormality, or an abnormality of the spine, or any combination of those things, you're actually well on your way to figuring this out. And they have some beautiful pictures in there of how radiographic findings can help. So here's a child with pseudoachondroplasia. You can see the anterior beaking here. You can see the metaphyseal abnormalities here, and you can see the epiphyseal abnormalities here. Now you probably get the sense that you may have to look at these closely and maybe sit down with your radiologist and look for some of these subtle signs. Depending on how subtle these are, they may not have picked these up. And so a trip to the radiology suite may be helpful. Here's another few pictures on the types of things that you should be looking for. So here's some metaphyseal abnormalities here, epiphyseal abnormalities here. This is widening of the diaphysis here. These are all different abnormalities. Here are metacarpal abnormalities and spine abnormalities in kids with skeletal dysplasias. So sometimes these are not as apparent as you would see in achondroplasia or in hypochondroplasia, but often you will get a pickup there. So kind of back to the algorithm, I think that we decided at the end of this process that it is probably a good conceptual framework and guide to the evaluation of children with short stature. It's not the be-all and end-all. I think that the one thing about guidelines is you sort of start with the evidence that you have, and in this instance there really was not a lot of evidence in the genetics literature on how to proceed. And you get people together and try to make some sense of what we all do. And sometimes that's the hardest part. We all kind of practice this way, but sitting down and putting it on paper is difficult. So I think that in the end, if I've gotten one thing across today in terms of how you evaluate these kids, is to sort of start by looking at them, get a good family history, find out how tall their parents are and how their parents grow. I think all of us have seen kids that are followed in endocrine or in genetic or in GI or genetics, and the parent comes in and they say, I weighed 40 pounds when I was 7 years old, and I was always like the runt. And you're looking at this fully grown person, and that really means something. And sometimes in those cases you just have to hold people off. But I think if you divide this into isolated versus non-isolated, and then you kind of work your way down the algorithm, you will actually end up in a reasonable place, perhaps not testing as many people as we need to. Now that insurance payers are really starting to fight back in some way on paying for chromosome microarrays. If you have a child that comes in with a good history for constitutional delay or familial non-pathologic short stature, who has no developmental abnormalities, who looks perfectly fine, that child doesn't need diagnostic testing. You can actually reassure those families. And sometimes you get that information just from the history, looking at a growth curve, and doing a bone age. But if they don't fit into those categories, then I think a karyotype is reasonable. Shocks testing is reasonable also, I think, after going through this process. And then if you're really down to, this child is dysmorphic, they have developmental issues, and they're short, and they are different than their families, then karyotype and microarray in whatever order you'd like to do those in, and I'm not going to get in the middle of that debate, is reasonable. So I will wrap up there and thank you all.
There's plenty of time for questions. Strikes me that the word constitutional must be another grab bag. Are there single nucleotide polymorphisms that are associated with constitutional, or for that matter, familial short stature? Is anything that explains? It sounds like something related to maturation.
I don't think anyone's looked. I think that I'm sure people are looking. I know that in our institution, Joel Hirschhorn has an endocrine fellow working with them now, and they're taking all kids that have a height less than 7%, and they're starting to do that. But I don't know that anybody's consistent. There's nothing in the literature that.
Great review. Thank you. I guess the only thing that occurs to me when I look at this is that I would want to do upper and lower segment ratios, looking for proportionality in everybody in that first phase, including the quote isolated. And it looks to me as if the algorithm has you making a decision whether or not to look for disproportionality based on, there aren't any other dysmorphic features or physical findings. So I would tend to want to do that in every patient with short stature, and then when it's proportionate, go on through the isolated part of it.
And I think that was implied. I mean, I think that, I had it under my pertinent findings group first, and I think that if you were disproportionate, you would kind of automatically fall into this other physical and developmental category. But I think you're right. Anytime you sit, I actually looked at this yesterday thinking, why do we do that? And then I started to say, well, where are the girls with Turners? So I think you can look at it, but I think you're right. I think that isolated really means just short stature. And they're not disproportionate, they don't look dysmorphic.
Other questions?
I can tell you the one thing, just in terms of the committee process with this. This actually, it was interesting to note how little dissension there was. In terms of, we always talk about the fact that we're all different, and we all practice differently, and we're kind of all, if we practice the way we were trained. But most people actually thought the same way. So, maybe that's a good thing for our specialty.
I'll actually make one comment for you, the podium was asking a question, and that is that when you made the point about the electronic record permits you to calculate the height velocity, it struck me that this entire algorithm could be put into the electronic record, and wouldn't it be possible for the record to monitor height automatically, calculate height velocity, flag the patients? That's not going to say you've got other anomalies or not, but a lot of what's in here could actually be embedded as a sort of decision support tool.
Hospitals now are kind of moving toward standard of care and quality measures. And you're absolutely right. You could put this into your electronic medical record, and if you code the patient as a patient with short stature, you can get prompts saying, did you do upper to lower segment ratio? If so, did you order a skeletal survey? To kind of help you through your practice.
Not the best or
Right, that's true.
Mira, is there a place we can find this MD report and that algorithm?
Genetics and Medicine, June 2009.
Should also be on
And it's on the web. It's on the college website. It's on the college website, yes. Thank you.
Just another question.
I think it's worth mentioning that under the Child Health Insurance Program reauthorization,
there's a project getting underway now to develop a model electronic health record for children to include in that some elements of decision support. Clearly, there's been a lot of focus on immunizations, but adding some decision support to growth data and the issue of everyone's calculating BMIs, which don't work very well when you're at the upper or lower extremes, adding some additional, more sophisticated review of outlier at potentially at both ends, tall as well as short stature, would be extremely helpful. And I really encourage you to try to raise the awareness at CMS that it should be part of a standard child health record. It should be something that's reviewed automatically for all children using electronic records.
Well, just understanding the capability of your electronic health record is also amazing. I didn't realize, we've had an electronic health record now at my hospital for 2 years, and growth charts have been in there, and the clinical systems put the growth in, so, when I see the child with NF, it pops up, and I can look at the growth. And I was sitting with one of our endocrinologists, who's a geneticist, and I said, do you need to see this child with NF? And she clicked on this thing, pulled up the table, clicked 2 things, and she said, that growth velocity is abnormal, yes. And I had no idea, really, that that was there. The BMI pops up, and it's flashing all over the place. So, I think a lot of this, at least calculating growth velocities, it's already in there because the endocrinologist made them embedded in there.
Is that our home drug system or?
I think it's commercial. I think it's SERN. I think they use SERN. Yeah. But it's wonderful.
Yeah, it may be there in some of the hospital-based systems, but the ambulatory primary care systems, where most of these children first appear, very rarely will have something like growth velocity. Because not enough people are asking for it in the ambulatory environment.
Well, the other thing is, and I didn't say this, but it was implicit, your height has to be accurate. I don't know how many times I've worried about kids falling off the growth curve, and then, I take them and remeasure their height, and it's, 2 centimeters greater than what's written on the sheet. So.
Is there any data right now on the microarray pickup rate?
With short stature? No. There may be in 2 months. We're going to go back and look at some